Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on Alzheimer's disease. We're joined by Dr. Agronin. Would you like to introduce yourself?
My name is Dr. Mark Agronin. I'm a geriatric psychiatrist and currently serve as a chief medical officer at the Frank C. and Lynn Scaduto Mind Institute in Miami, which is a full-service and comprehensive memory disorder center located at Miami Jewish Health.
Thank you, Dr. Agronin. Dr. Porstensen, would you like to introduce yourself?
Absolutely. Thanks, Chris. So Dr. Enta Thorstensen, I'm also a geriatric psychiatrist. I've focused singularly, though, on the care and study of people with memory disorders since about the mid-1990s. I spend about 30% of my time in a specialized memory disorders clinic here at the University of Rochester, where I'm a professor, and 70% of my time doing clinical research.
Okay, and thank you, Dr. Porstensen. And Dr. Ramanan, would you like to introduce yourself?
Thanks, Chris. Good to be here with all of you. I'm Vijay Ramanan. I'm a behavioral neurologist at the Mayo Clinic in Rochester, Minnesota. I direct our Alzheimer's disease treatment clinic here. I'm also involved in clinical trials and observational research focused on blood biomarkers and genomics. So great to discuss.
So the question that we like to consider broadly is what's the role of amyloid beta in Alzheimer's disease? Dr. Ramanan, if we could start with you, can you maybe walk us through what amyloid beta is, the role in the pathophysiology of Alzheimer's, and how this knowledge has influenced our approach to diagnosis?
Certainly, big topic, and my colleagues will add where I leave some things out. But amyloid beta accumulation, it's accumulation of a particular form of a protein. This is one of the hallmark protein markers of Alzheimer's disease, the other being tau formed in neurofibrillary tangles. In Alzheimer's disease, amyloid beta protein accumulates into plaques that are outside of the neurons. Based on observational studies of individuals throughout the aging process, some of whom develop symptoms of cognitive decline, some who may not, we do know that amyloid plaque accumulation is an early marker of Alzheimer's disease. It's something that can occur over 10 to 15 years, even prior to individuals developing symptoms of the disease. And there are other pathophysiologic processes of Alzheimer's disease which develop along that time course, but amyloid accumulation being one of the early factors in the disease. I think it's hard to ignore the idea that amyloid accumulation has a role in the disease process when you look at that observational longitudinal data, when you also consider that some of the individuals who develop relatively rare but very young onset genetic forms of Alzheimer's disease, that in those cases there can be mutations found in genes that are directly involved in the production of amyloid beta protein or the processing of some of its precursors. So when you take all of those things into account, I think there are several reasons why amyloid has a role in the disease process. But as I mentioned, it's a complex disease. There are multiple factors in the pathophysiology. Some of them can evolve over time, including the fact that individuals can have abnormal accumulation of amyloid plaques in the brain, and at that particular time point, they may be cognitively normal. Now, if they were to live long enough, is it possible that some of those individuals may ultimately develop cognitive decline? Certainly. And there are, amongst those other measures of the disease, other markers of the disease, some tighter correlations between things like tau accumulation and its distribution and markers of neurodegeneration as relating to cognitive decline. But in summary, that accumulation of amyloid beta plaques in particular, an early marker of the disease process, something that can happen, in fact, long before folks may develop symptoms.
Yeah, first of all, I want to compliment Vijay on just a power overview of the role of amyloid, because amyloid is critically important. It's not the only thing in Alzheimer's disease, but it truly matters. And there are various isoforms of beta amyloid. There's good beta amyloid and there's bad beta amyloid. And basically, this is an end product of the breakdown of amyloid precursor protein. And the shorter fragments, so 38 and 40 seem to be more benign, but particularly the 42 amino acid fragment seems to be neurotoxic as an individual unit, but it also tends to polymerize and form oligomers and protofibrils, and then the amyloid plaques that Vijay spoke about. So as he pointed out, this process doesn't happen overnight. When I started in this field, we basically looked at amyloid and Alzheimer's disease as if Alzheimer's disease, you woke up one day with the dementia stage. And now we understand that the disease is dimensional, that it has a preclinical state, it has a prodromal stage, and then the dementia stage. So we can now measure amyloid in its various forms through what we, as a group, refer to as biomarkers. And biomarkers can visualize fibrillary beta amyloid in the plaques as an amyloid PET scan. We can look at soluble forms in fluids, and that includes both CSF as well as blood, and blood is growing in terms of importance. And there we can measure A beta 40, we can measure A beta 42, and we can measure actually other proteins that reflect the degree of amyloid burden, maybe the most sensitive and accurate being one of the p-tau, so p-tau 217, which recently was cleared by the FDA as a blood biomarker in Alzheimer's disease. So the importance of this is that Alzheimer's disease has kind of changed from being just a clinical diagnosis to actually us having the ability to do a biomarker verification. And the diagnostic criteria that we have used basically over the last 2 decades have evolved to reflect that basically we can biomarker verify the disease so that we have actually a very high confidence that somebody has elevated amyloid burden. And if they have no symptoms, well, that may be that they just have the Alzheimer's pathology and no clinical symptoms. We refer to that as preclinical. But in the clinical stage, we may either have the mild cognitive impairment form or the dementia form. And that's kind of where we are at least with treatments that we can prescribe today, although research kind of looks at the full spectrum of disease.
Sure. So it's remarkable this new era we're in. Just turning back the clock several years ago, Alzheimer's disease was primarily a clinical diagnosis. And the challenge was trying to know whether we really were dealing with Alzheimer's disease or some other form of neurocognitive disorder. Certainly today, biomarkers enable us to make more definitive diagnoses. So the real question is then, what are we going to do about it? And when we think about treatment, there's many different approaches, but I'm going to divide it up into 2 buckets. So one is just the fact that someone has a neurocognitive disorder indicates the need to, make certain that anything that's good for the brain we promote, like exercise, a healthy diet, something like a Mediterranean diet, making certain that anything they're doing, such as drinking too much, using certain medications that impact the brain, not controlling blood pressure and cholesterol level, things like that we address those. but basically setting up a brain healthy environment for the person, which will help certainly with wellness, but also with improving their course. So that's one approach, and that applies pretty much to everyone, regardless of whether we know specifically they have Alzheimer's disease or not. So the big difference now is with our ability to make a more definitive diagnosis, we want to help to improve symptoms, and there are a number of medications which can lead to symptomatic improvement. These are very familiar to people. The acetylcholinesterase inhibitors like donepezil, rivastigmine, and galantamine, which can, by improving cholinergic function, can have an impact positively on memory and other cognitive skills, also function. And those are indicated from mild to advanced stages of illness. We also have a glutamate receptor antagonist, memantine, which can decrease a type of neurodegeneration we feel is associated with excess glutamate activity. And this can also lead to some symptomatic improvement. And the goal is to do a combination therapy once we get into moderate stages. These treatments have been around for many years, and they can help modestly with certain people to improve symptoms, but we're really not getting at the disease itself, at least not at first. So now that we're able to show with more certainty that people have beta amyloid deposits in their brain, the question is, what can we do to get rid of those? And if our theory is correct, at least in part or whole, that amyloid is one of the main causes here, if we can reduce the burden of amyloid plaques, that should have an impact on the disease course. Indeed, what we've seen through a number of studies over the years looking at immunotherapies that give individuals antibodies that attach themselves to different species of amyloid, whether fibrils or plaque-bound amyloid, can activate the immune system. Basically, the microglial cells through phagocytosis begin to literally eat up or dissolve amyloid in the brain. What we've seen in clinical trials, in particular for the two FDA-approved immunotherapies, lecanemab and donanemab, that over the course of 18 months, we can not only significantly reduce the burden of amyloid in the brain, but this has been associated with roughly a 30% on average slowing of the disease course. Now, certainly some people have less, some people have more, and we're really working to distinguish, how we can stratify that to some extent. But the bottom line is that we've really had good success in terms of slowing this disease course. These are the first disease-modifying treatments. We should note that we're not getting people better per se. We're slowing the course of it in ways that can be meaningful in a variable manner. The challenge is we don't really know what someone's course would have been otherwise. And so even though we can say based on the data we're slowing it down, we really don't have a good comparison, aside from the fact that we certainly can look at things like an amyloid PET scan to see a reduced burden of it. In terms of the impact clinically, that's variable. But this still has moved the needle in a very significant way in terms of treating this disorder. These medications do come with potential side effects as we mobilize and remove beta amyloid from the brain, in particular also in small blood vessels. Some individuals can get microbleeds, they can get vasogenic edema from this, often asymptomatic, but we need to do regular surveillance for this, and they can be symptomatic. So it's a new era in which we can actually modify the disease. The hope is that down the line, we also, in the ongoing clinical trials, looking at other ways to address either amyloid and eventually tau, or to address other aspects of this disease. But the fact now that we can actually have a meaningful impact on the course of it can make all the difference, and it can give people hope that they can have a greater period of normality as this disease is unfolding. The key thing here is early diagnosis, because these treatments have been shown to have benefit in early stages of it, which really behooves us to get people in, to be screened early, to make an early diagnosis, to not only get all the other aspects of treatment put together that I mentioned earlier, but to get these immunotherapies applied to people and really give them a much better course over time.
And I want to briefly echo actually what Mark said there at the end, and that is early diagnosis, and emphasize that. And there's actually data from the lecanemab and the donanemab studies, as well as from centers that have treated by prescription large numbers of participants, that seem to strongly suggest that the earlier you intervene, so even early in the MCI stage, that basically those individuals seem to have, number one, better clinical outcomes, and number two, maybe lower complication rates. And there I'm specifically talking about ARIA, so the localized swelling or the microhemorrhages that you can see in a subgroup of people getting those medications.
That is a complex and evolving area of discussion, even within experts in the field. One perspective to keep in mind, as Mark pointed out very well, a primary goal of these anti-amyloid therapies is to clear amyloid plaques from the brain. And so a main outcome in the clinical trials testing the medications, a main thing that we would look for when prescribing these medications in the clinic is, are we making progress in clearing those amyloid plaques from the brain? That process of plaque clearance, it can vary from person to person, and likely there are some individual specific factors, maybe some drug specific factors which contribute to this. Where you start in terms of the amount of amyloid burden that you begin with pre-treatment can impact this, but based on the clinical trials of both lecanemab and donanemab, by an 18-month marker, somewhere around 75 to 80% of patients will have reached an amyloid negative status. Some of those patients may reach, as soon as 6 months or 9 months or after a year of treatment. But that is a main goal of the treatments, and as my colleagues pointed out, earlier is better, and some emerging data pointing to the briskness with which you can clear those plaques from the brain, get somebody to an amyloid negative status based on your biomarkers, the better the outcomes potentially. There's more research evolving in that area. But that may not be the only thing to keep in mind. As currently written in the drug labels themselves, lecanemab, one of those medications, primarily written or intended to be given over an 18-month time frame. At that 18-month time frame, there could be options for patients. In our clinical practice, we've encountered some patients who, if they've cleared their amyloid at that point, they're amyloid negative by our biomarker assessments, they may elect to discontinue the treatment and continue observation or monitoring. For other patients, there's also the option to continue on the lecanemab therapy, and there's even a maintenance dosing protocol that's FDA approved that has a little bit less of a dosing frequency, so once a month instead of every 2 weeks. And coming back to something that Anton mentioned very well earlier, there are different species of amyloid here, and part of the rationale for thinking about continuing with use of lecanemab, perhaps in a maintenance form after that 18 months, rests on the idea that that drug has some selective ability to target soluble species of amyloid, which can have neurotoxic effects on their own, can be considered in some ways as seeds for future plaque reaccumulation. In contrast, donanemab, as written and as considered generally in most appropriate use guideposts, is intended to be given until someone can reach an amyloid negative status. And so there could be, as we're discussing with our patients on an individualized basis, these could be factors which could influence their decision making of potentially which medication might be the most appropriate, thinking about things like the dosing frequency, looking at the side effect profiles from the data that we have in clinical trials and early clinical practice use, considering the longer term goal. Do I want to try to clear out my amyloid plaques in, say, 6 or 9 months and then be in a position to stop those infusions? Or is this something that maybe I would consider as a continuation part of my management and consider other opportunities to add to that down the road? Part of why we don't yet have all of the hard and fast answers on this just comes back to the fact that these medications are relatively new, really have been out on the market for 12 to 24 months. Certainly we have clinical trial data from released publications and conference presentations to help guide us. But as those patients, both from the research studies and from early clinical practice, continue to have their longer follow-up, to have 3 years and 5 years and 7 years and 10 years worth of data, that will really help guide refined use of these medications and perhaps additional stopping criteria as we look ahead.
So I'm wondering, now we have these amyloid beta targeting drugs. What are prospects for other treatments that target beta amyloid?
There's certainly lots of different candidates, looking at ways to target different amyloid species. ALZ 801, for example, medication, it's amino acid derived, also helps in terms of at least theoretically preventing aggregation of amyloid in the first place. If you can stop the drive towards these plaques, that certainly could play a role. It's certainly in terms of tau as well. There's a quest to find the best immunotherapy. Which part of tau do you need to attach to really robustly remove it? The thinking is that tau may actually be the more damaging element here, and so if we're only addressing amyloid and not tau, are we just getting half the story, which may be why we're not really helping people improve. We're just simply slowing the rate of this. So, many other candidates that we're actively looking at now. I think over time, we need to resolve, amyloid and tau is at where everything's at, or is there something more fundamental driving them that we need to get at that we don't fully understand? But without question, there are more elements there. But this speaks to the issue of getting more people involved in clinical trials and how we do that. And certainly without that, we're not going to move the needle.
I completely agree with Mark, and maybe two other guideposts to add here. Considering some of the newer generation anti-amyloid therapies that are currently under research, some initial data pointing to perhaps better ability to penetrate into the nervous system, so offering the ability to perhaps use lower doses, lessen some of the peripheral side effects like infusion reactions, potentially lower ARIA rates, so additional research to come in that aspect. And then the other that Anton hinted at very nicely earlier was the use of anti-amyloid therapies even earlier in the cascade, so in the preclinical phase. So research will guide whether that may be something that enters our clinical lexicon in the future. An individual who has amyloid plaques in the brain, we can consider them as at risk for developing cognitive decline in the future. Do you go in with an anti-amyloid therapy to clear away the plaques and either prevent or delay their developing cognitive decline down the road?
As we celebrate the fact that we have the first two approved disease-modifying treatments available to us for prescribing, we should also celebrate that there is still a large kind of push to develop new treatments. And Mark talked about the different drugs targeting various points in the amyloid processing, and that's both small molecules and antibodies. And Vijay highlighted that we're trying to make better antibodies that are distributed more easily into the brain and within the brain tissue, what we call brain shuttle technology. But also antibodies that may target different binding sites within beta amyloid. That will be one part. Targeting tau is done through antibodies, is done through antisense, and through RNAi. We're also seeing antibodies and small molecules targeting neuroinflammation. We're seeing drugs targeting metabolic derangements. Actually, at the end of this year, we're going to see results from two very large studies using a GLP-1 agonist, which is one of the new anti-diabetes and obesity medications. And I don't want us to overlook also the development for neuropsychiatric symptoms in Alzheimer's disease, where we have the first drug approved to target agitation and aggression, and multiple other drugs in development targeting agitation, targeting psychosis, etc. So it's an exciting time, and we need to improve these medications because the ones that we have now are not for everyone. There's a substantial number of people that we have to look at very carefully. Are they appropriate, even if they are in the early symptomatic stage of disease? I think that the main thing that I would like to just point out to people, we've talked about disease-modifying treatments, and I think that it's just critical for people to understand that it's wonderful to have them, but you have to select the patients that are most likely to benefit. And you have to be very thoughtful about your clinical monitoring and setting up collaborations with the patient, the care partner, the infusion center, because these have to be done by infusions, with your imaging colleagues, and the PCP. That this team needs to work together to kind of oversee this management. And with that, I have to say that I've been pleasantly surprised how well things are going since we moved from the clinical trials into clinical practice. That in clinical practice, we are doing just as well in terms of overall safety and tolerability as we saw in the clinical trials. And many of the kind of skeptics about this were predicting that we would have real difficulties once this came into general use.
I'd like to thank our experts for sharing their insights with us today. We hope that this podcast will be valuable for you in the way that you treat your patients. We look forward to having you join us next time.